Hello, everyone. Welcome to the call, Surgeon Wellness during COVID-19, Peer Support, March 26, 2020. Jeff, take it away.
Hey, everyone. Welcome to our, in essence, second Surgeon Wellness during COVID-19 peer support call. This one we're kind of describing as a community focus group, having the opportunity to share stories, hopefully leaning towards the positive, knowing that this is a really tough time for some people in particular, if not all of us. But we look forward to lifting each other up is kind of how I like to say it today. Paul, what we wanted to also do is share what we learned on the last call. So why don't you show the slide, our first slide there that just shows some of the take-home messages or key points that we got from our March 18th call. And for the next few minutes, we're just going to highlight about 10 points that we think were the most salient points from our last call. And we have a great opportunity to have a discussion here with all of you, as well as a couple of people that have volunteered to make some comments on the call. And one of them is here with us right now. I'll introduce him now and won't ask him yet to jump in to speak, but at least say hi to everybody. This is Dr. Greg Mundis, an orthopedic spine surgeon from San Diego, but that's not where you're at right now, is it? Where are you at, Greg? Is his mic working? Are you working?
Yeah, I hear you.
We need to unmute him. There we go.
Yeah, I got it. Yeah, so I'm presently in Springfield, Missouri, so Southwest Missouri, tending to my folks.
Awesome, and thanks for joining us, because I did want to share the story of another surgeon who's actually been directly touched by the COVID-19 pandemic, and wishing you and your parents absolute strength, and I know you have strong faith that you're tapping into at this time, and obviously tapping into just the strength of your father and both your parents. So we'll get to that shortly, but thank you so much for joining us.
Absolutely happy to be here.
So that's a little bit what we've been doing. We had the discussion last time. We had people sharing some of their personal experiences just as it was approximately a week ago. Things changed pretty rapidly, but I think some of the key points that we got from the March 18th call would apply even now on March 26th. But we're all learning in the process here. Hoping that folks can kind of jot down some of these notes. We're glad to share them in a different venue, but here they're up for everyone today. Some of the dynamics are that anyone in the audience can raise their hand. We'll try to open up your microphone individually, as well as we'd like to share video for those that are willing to have their video shown while they're speaking. Logistically, that's a little tricky, but we're going to try and do it. And then I want to be respectful of anyone that's on just wanting to watch and observe. I don't want to necessarily call out anyone accidentally, even if you're a friend or colleague, unless you want to. If you're open to having me share ask you or reach out to you, then you can put that in the chat for us so that I can feel more comfortable reaching out to folks. Because Greg's agreed to this ahead of time, and other people may or may not have agreed to jump on the microphone and be sort of a visible panelist. So that's kind of my opening. Without seeing any other requests or comments from the chat, I'm gonna go ahead and invite Greg to share his story. I mean, there's probably a lot to tell, but start somewhere, and maybe we can fill in, and people might have some questions. And I'm going to mute myself because I guess you guys can hear the wind in the background. So hold on 1 second. Go ahead, Greg.
Cool. Well, thanks, Jeff, again for doing this. I think what you have going on here is so appropriate given the circumstances that we're currently in. I think there'll be a couple interesting things that we can probably go towards as this webinar progresses, and perhaps one of them is the impact of this virus potentially, or the potential impact on us as surgeons. We can talk about our emotional well-being and physical well-being as well, but I think there are some points to be made about safety to our patients and to ourselves, truthfully, during this pandemic. So, and I think it probably deserves highlighting. I'm not for sure if you heard about the new study coming out of Italy showing that there have been 24 surgeon deaths so far already. So there's a problem there that we're clearly not immune from. So, but just to give you my story, I guess, in a little recap is about a week and a half ago, or almost 2 weeks, actually 2 weeks ago today, my dad started developing some symptoms after having been exposed to some of his friends from France that were COVID positive that they figured out at a later date. He started having symptoms 2 weeks ago, had kind of the usual testing and run around by the primary care docs out here. Mind you, Missouri is probably about a week to 10 days delayed behind Southern California. So our preparedness there was non-existent here at the time. Then over the course of the weekend, he kind of got sicker, more lethargic, never had a cough or any shortness of breath. Monday started to not be able to really communicate well, wasn't able to walk well, was crazy weak, got tested that day, made it home by around noon. As soon as he got there, 911 was called. He was taken to the hospital and was intubated about 4 or 5 hours later. We received a phone call a couple hours after that, notifying us that my dad was highly likely not going to make it through the night. So I hopped on a plane at that point to Missouri, expecting the worst. And we're about 10 days into it now, and he's still fighting the good fight. He's had to be on dialysis a couple different times already because his kidneys shut down. But fortunately for us, he's in a very good medical center where he's being cared for very well. My mom is a separate story. So a week ago Monday, so 10 days ago, my dad started being symptomatic. My mom started being symptomatic about a week ago. And as soon as she had a fever, she actually had the health department from Greene County calling her every day. As soon as she spiked a fever, they sent her into the ER. She got tested there. And we actually, when I got the phone call from the ER doc, he asked if I wanted to do anything else. And I actually started her on hydroxychloroquine that night. And she's been on a 10-day course of it, which is a little bit longer than most, but she's over 60 years old, has chronic asthma and diabetes. So she's in a very high risk category. So we got her initiated on that treatment. She got admitted for 3 days over the weekend. Actually had a prolonged QT interval from the medication, so we had to modify the dose a bit. But now she got discharged home on Monday, and happy to say she's had, the last 4 days has had 2 good days, which is 2 more than she's had over the last 10 days. So in addition to fighting for her best friend's life, she's having to deal with her own physical ailments and being in isolation at home because she's got nobody else at home with her. So it's been an interesting time, socially, emotionally, physically, dealing with, living in a hotel room now. They allowed me to see my dad for the first 3 days. And then basically after that, asked me not to come to the hospital anymore. And a day after that, they shut the hospital down to all guests and visitors. So again, lagging about a week or so behind from where we were in Southern California. So that's the story in a nutshell.
So I want to just remind everybody that please feel free to type in a question on the chat. And even if we don't have any immediate questions, but if people come up with questions, if Greg's able to stick with us
for sure
for much of the call or some of the call, if he's still here, we're definitely going to get him to speak up and answer some questions. And by the way, if you don't mind, Greg, I'm going to keep you as co-panelist, co-moderator on this. If you have questions that you want to ask people, feel free to share that. So, I mean, this is pretty tough. I imagine in your situation that, and I just watch you doing it so well, just following you on Facebook. Just you mentioned kind of the number of surgeons that in Italy that have died. I think, paying attention to your own wellness and that of potentially your colleagues. Anything that you would add to to sharing about surgeon wellness, of things that you've maybe learned in the last 10 plus days?
Sure. Let me take two approaches, if that's okay, Jeff. The first will be to our physical wellness on the job, so on our practice. And then the second will be our wellness apart from our job now, because those worlds are very blended for us almost all the time because we're so busy. But they're becoming more disparate now. They're very much two different worlds now that we're having to deal with a lot more, and hopefully for the betterment of our wellness in general. So let's take the scientific route first. The concern with surgery in general is that we're taking patients that have a virus that transmits through an aerosolized, typically aerosolized route, and we're taking them to the operating room, we're putting them to sleep, we're sticking a tube down their throat. Everyone's getting exposed to it at that point, even in asymptomatic patients. Wuhan actually published a paper on one patient infecting 14 healthcare providers with one elective operation. And that was an asymptomatic mid-adult, 40-something years old. So this stuff happens, and it's kind of the perfect storm. So most of the masks that we wear in the operating room are not to the specifications that are for patients that have these aerosol precautions. So you think you're wearing a mask that's protective, and it's probably not. So you got to check on what masks you're wearing, if you're not already wearing some of the, like the total joint suits. The next thing is the way our rooms are typically ventilated is in such a way that prevents bacteria from migrating in and out of the room, but it kind of creates a petri dish for those viruses that are going to be inside that room. So it's sort of like a perfect setup for us to have problems for patients that may be asymptomatic or haven't been tested or are COVID positive. We just don't know it. And so for that reason, I think the Italian experience is telling us, you got to be pretty aggressive about shutting things down and, taking a real stance towards social responsibility, not pushing the limits on what's an indicated procedure and what's not. Because if it can wait, 3 or 4 weeks, it should. If it can't, well, then we got to do what we got to do. We still got to take care of our patients. So that would be one end of it on our wellness, is to say that I think we're at higher risk as surgeons than even, say, the medical docs, because of the environment that we find ourselves in with our patients. The other thing they were finding is that there's some concept, at least, that especially in orthopedics, where there's a lot more, it's a little messier, right? To say it nicely, is that messier environment may be opportunistic for the virus as well. So it's just important to recognize that.
And Greg, let me make one comment that
sure.
I haven't looked at the survey for today, but on our last call, 25% of the people on the program were vascular surgeons.
Wow.
And another, I think it was 10 to 20%, or actually at least 50% were non-orthopedic surgeons. So it was about 50% orthopedic, but just so you know.
No, it's perfect. I think it's very apropos. They've actually even shown, I don't know if there's any ENT surgeons on the group here, but certainly, I mean, God love you guys. Please be careful. I mean, do whatever you need to. Go to extra lengths to protect yourselves. It's just not worth it, because it's not just you, it's your families, it's your grandparents, it's people that you're coming in contact with that may be higher risk. That's where it really, where it really matters the most. So, but thanks, Jeff, for pointing that out. That's really important. Then there's the other side of things. So this has been interesting for me, because for 3 days, I got to go to the hospital 3 or 4 times a day and spend time with my dad. And that was pretty easy, right? I go there, I pull my iPad out, I pray over my dad a bit, and then, just do some reading and get caught up on email and just kind of be around my dad. But then I got, like I said, on that Thursday, so it's been a week now since I've been kind of isolated in my room. I sort of forced myself into a routine. Time when I wake up, Zoom chats with my family, get everybody caught up on board. I take an hour to work out every day in my room. I actually went to Walmart and bought a pull-up bar and a yoga mat. So I'm in my room. I have a workout that's in place every day. I take time to read and be by myself and shut everything down. So no computer, no phone, nothing. It's all shut down. And then I got myself spending usually, you know, somewhere 3 to 4 hours in the day doing my work, which would be emails, communication, calling patients when it need to be called, coordinating care, that kind of thing. And then the evenings, just trying to make sure I have a good cadence to my diet. I've been relatively carb free, just trying to take care of my body, knowing that, you know, I'm trying to push some of the more foods higher in vitamin C and vitamin D a little bit. And then I've been doing some supplements as well. I have that airborne stuff at home that has 8 milligrams of zinc in it, which is supposed to be immunoprotective from viral etiology type of illnesses. Not sure it's necessarily specific to COVID, but again, kind of the point of having a cadence to your day, I think is important. And we're so used to getting up at, you know, 5 or 6 in the morning, headed to work, round, you know, operate or go to the office and do our office work or operate all day long, go home at 5 or 6, be with our kids, put them to bed. And then that's our cadence to our day, and spend time with our wives and then call it a night, you know, and you fit the workouts in there here and there. But I think we're all encountered now with a time when we don't have that normal cadence to our lives. And I think it puts us at a little bit at risk to not being well, truthfully, because we're so used to being in the daily grind for, you know, decades, and so for some of us decades, you know. And so I think establishing a new routine for yourself is really important. And I can't highlight that enough. Your diet and your exercise are probably more critical now than they will ever be.
Excellent. Thanks for sharing that. Greg, are you able to see the chat? There's just a couple comments, but one of our guests just said, thanks for, you know, sharing your story, and we stand with you.
I appreciate that. Thank you, Max, very much. I'll throw something else out there. Like, when else in the lives of surgeons have we had like dedicated time to like love on our kids and to love on our wives and make them feel like they are the most important people in our world? And I know hopefully most of us try to do that. And I should say husbands and wives, excuse me. But like, this is a time I think that, man, I'm actually, you know, I'm hoping to go home on Sunday. I'm really looking forward to being home. Scripps Green shut down for the next 2 weeks. So we actually don't get to operate until like mid-April now on elective spine surgery. So, and that's a minimum. So it could even go beyond that. I guess my point is, you know, I get to go home and really invest in my family. And I think that's really important. And we should take that opportunity to teach our kids anything we can, honestly. Just live with them, love them. Same with our spouses. Just taking this opportunity really to show them how meaningful this is. Obviously, I have a little bit different perspective as I've been dealing with death for the last 10 days. And certainly it's very, you know, it's very personal and in some ways even refreshing for me. I feel far more alive now than I did probably 11 days ago.
And so when are you thinking of coming back?
Probably Sunday. Yeah. If my mom remains afebrile for sort of 2 or 3 consecutive days, I'm mainly staying for her. I can't care for my dad at all. I can't even see him. So I get on the phone with him every day and talk to him. So, but everything I'm doing is via phone calls with the ICU docs and the nurses. So that's not going to change at all. My mom has another like week and a half of being alone at home before I can actually be with her. I've been bringing her some food and things like that, dropping at the doorstep, but I can arrange that as well. And as long as she's feeling better and I know that she's not going to need to be readmitted, I'm going to feel comfortable getting out of here.
Awesome. So I hope that continues in the direction that you're describing, and it's these stories are almost hard to imagine without hearing it from someone who's actually experiencing it. I mean, we know we're all impacted and affected, but just your experience is something that some of us are absolutely not currently experiencing.
Yeah. Thank God. We don't want anyone to experience it, you know? That's a little bit the funny thing about it, right? Like, success would be as if this thing turned into like fake news, right? We know it's not, but if it doesn't impact our communities and doesn't impact our hospital, that means we did it right. You know, to say that you have to have an outbreak and have to respond to it before you feel like you were prepared is not the right way of thinking, right? The best way this could ever happen is for us to have taken 2 or 3 weeks off and the outbreak never happened in our community. Like, that means we did our job. We were socially responsible, not socially arrogant.
Excellent point. So have a good comment in the chat from Dale. Let me just reach out to Dale if he's willing to be unmuted, and also whether he potentially would jump on. Let's see, have we unmuted him? Or he might need to unmute himself if he wants to share what others who might not be able to see the chat, because some people are just listening and can't see the chat. Dale, are you there? I think he's unmuted, right? Try one more time, Dale, see if you can speak. I don't know if that's working. We'll keep trying that. We'll leave. There we go. I think, or is that Greg talking?
That was me talking, but I see Dale's name pop up. There you are. Hey, Dale.
There we go. Coming in. Still waiting on the audio. It could be a microphone in the bottom left corner of Zoom. Or it looks like a telephone. And then what I'll probably do is I'll have Paul problem solve on that until we can hear Dale. Or in the meantime, I can read your comments, Dale, if you want to just nod your head, if that's okay. Okay, I'm going to read Dale's comments here.
It's kind of like talking to my dad, by the way. Hey, Dad, can you nod your head? Like, yeah.
Cool.
I've gotten good at that.
I've been fairly protected as I do pediatric orthopedics in Kansas City. No COVID-19 positive inpatients yet. Hank Chambers organized an amazing webinar, Pediatric Orthopedics in COVID-19 World. Speakers from Milan, Nancy, somewhere in the UK, Seattle, and New York City. One of the take-home points from Seattle was that they test all pre-op patients if possible. I've also read that non-intubated COVID-19 positive patient who needs surgery should be, I think that is intubated in a negative pressure room so as not to spray virus upon intubation. What are other people's institutions doing? And thank you for the gender. Until I had the audio or the video, I couldn't appreciate it. I'm sorry about that. But we're still having trouble with the audio. Paul's going to work on that. Paul, do you want to see if you can promote Ryan? Hey, Ryan, how you doing?
Good. How are you guys?
You're on with a few of us and lots of listeners, so feel free to chime in and give us some perspective from the state of Washington.
Yeah. So I practice in Olympia, Washington, which is about 60 miles south of the West Coast center of COVID right now of Seattle. We've been about a week now. We've shut down elective surgeries. All surgery centers are shut down throughout the state. The governor has a shelter-in-place order out, and the soonest elective surgery will start in the state of Washington is May 19th. And out here, so far, most people are sort of dubious as to whether it'll start that soon. I practice out of a about 400-bed hospital that is kind of at the southern end of Puget Sound. So we kind of have a big geographic footprint in terms of coverage, and we've been able to kind of free up beds. We still have some ICU beds free from our, the baseline level of ICU beds that we have. I do want to comment that it's amazing how fragile our whole systems are throughout the whole country. For example, we only have 33 ventilators, not counting anesthesia machines in our hospital. The next hospital closest to us has about 14 ICU beds. So there's not a lot of beds to go around. In terms of number of positive cases here in Western Washington, there's about 1,400 or so. In Seattle, about 150 in the Tacoma, Pierce County area, which is between Olympia and Seattle. And then right now in Thurston County, which is Olympia, we have about 15 or so cases. That's also recognizing that we have a minimal testing happening out here, and the lag time of testing is anywhere from 3 to 7 days, at least out here. I know in other spots they may have more rapid testing. So that's sort of the overall situation and mood out here in sort of week one of kind of clampdown here in the state of Washington.
So, and any of our panelists that we have a microphone working on, I don't know if Dale's is working yet, can chime in with a question for Ryan. So feel free, Greg, if you have a question.
Yeah, maybe let's go back to Dale. Are you there? Can you?
I am here now. I had to
awesome.
adjust my settings.
Yeah, why
Can
don't
you
you share? Yeah, you sound great.
Hey, great. No, I was really quite taken with the fact that Seattle Children's tests all their preoperative patients, and I'm thinking that's incredibly proactive, considering that there is more of a risk, from what I understand, of a child being asymptomatic but shedding virus than an adult. However, just today, we've been getting twice daily updates from our administration. I've been very happy with them, but they seem to be downplaying the issue of asymptomatic children. What are your thoughts?
Is that to me?
Oh, to whomever. How's that?
Or
or actually,
whoever?
Okay. Whoever. What's being done in general in hospitals if someone is going to have a surgery without an obvious COVID diagnosis? If there is a lag in testing, do they assume that they may be positive and take great caution in how they're intubated?
So I'll speak for our institution. Currently, we have a perioperative committee made up of 6 or 7 surgeons plus representation from anesthesia and nursing. And we vet currently every single case that gets put on the schedule for necessity, as well as do we have enough staff and PPE for everyone to do any of these particular cases that come in. So that way we can try to have enough equipment to take care of it. We're functioning under the standpoint of that even if they're if we don't know, we have to consider them positive. But the challenge is that if you're in the operating room environment, you need some PAPRs, not just N95 masks, and we only have 10 of those in our entire hospital, and they all will have to be reused. So who knows how good they're going to be after we use them the first time. So that's certainly one of the challenges that we have in sort of trying to figure out how we're going to deploy these scarce resources.
Yeah, I can only speak for what we're doing at Scripps, but we're not screening routinely right now. And I'll give you my personal perspective. We absolutely should be. I kind of feel almost, Hamburg came out with a 4-hour test that we actually had access to here in the U.S. And then our administration said, no, we're going to develop our own. And here we are 2 weeks later, still trying to develop our own. And that sucks because, if you look at South Korea's success as well as China's, it's because they're so much more aggressive in testing, and they're testing everybody. Like for sure,
Yep.
like any type of surgical cases would all be tested. You know what I mean? So the problem is that we have such a lack of testing right now. I mean, we report 80,000 cases here in the U.S., but we all know it's like way the heck more than that. Thank God the deaths aren't as high, right? So, my thought is we should be testing everybody. We should be testing healthcare providers. Honestly, we're in there in the rooms and taking care of patients that are at risk, and we should be tested too. So, doesn't mean you have to be just when you're positive. You just got to know that you can't come to work if you're negative.
Right.
So, isn't there a fairly high? I mean, there's a high variability on the turnaround, and just looking at the state of Washington, just the diversity from one institution to another as far as the testing is so variable. It's really intriguing.
Yeah, and no question about that. We're still on about a 3 to 4 day delay for the most part. It sounds like Cleveland Clinic came out with a 4-hour test here recently. I'm not sure when that'll go into mass production, but that'll be crazy beneficial once we have a short one that we can actually go really quickly. Max, I think you posted the link to the Bloomberg article that I was referencing earlier. It's a really good article that we should all become familiar with, as it describes how surgeons or perhaps at higher risk than they realized in that article. And just like Max highlighted here is, sort of treating everyone like they have the disease is similar to the era when HIV was so dominant that we treated everybody as if they had HIV, and that kind of became the new universal precaution for that period of time.
Yes, thanks for sharing that. And I don't know if anyone knows the answer, and I've one of my challenges for my own personal wellness is going to the sources to read and get the information and then getting distracted into the comments and seeing what people are saying, and then it kills a huge amount of time, and I just don't have that much time on my hands. So I've temporarily paused my reading and try to limit, the occasional one that seems to be more scientific, but not all scientific, because there's other issues being raised. But I'm curious because I've heard some of the testing. We're good friends with a bioscience company owner in San Diego that's come out with a COVID-19 testing. It seems like a pretty high supply, but this is not a nasal swab. It's a blood test, and it's an immune response test. So again, to me, there seems to be high variability of the types of testing. Again, it's great. It's innovation. It's problem solving. I love that there's so many people doing that. But then it makes it really difficult to use a universal language like testing when we don't know exactly what we're testing and what the value of the positive means. And then if I say I'm positive on a test, but I go to work because it's a different test, then I can be shamed or blamed for even showing up at work. But guess what? That kind of test could be positive 2 weeks from now and 10 years from now because of the kind of test it is. Right? So I don't have the answers to that. To me, that's just questions. Ryan, I know that you also, besides being a practicing orthopedic trauma surgeon in the state of Washington and in Olympia, you're also involved in I think it was an ad hoc committee, but you can fill me in as far as a committee making some of the forward-thinking decisions about what kind of surgeries would proceed, and some of that triage of a mix of surgeons getting together. Do you have any comments on that particular subject of just proceeding with surgery and decisions for surgery?
Yeah, so while the decision to cease elective surgery was kind of pretty straightforward in terms of straightforward hip and knee replacements and, lumbar spine fusions, for example, it gets a lot harder when how elective is a CABG, for example, how elective is an EGD, because endoscopy is under the operating room area at our facility. How elective is an endoscopy case? Can a bronchoscopy case for someone potentially with a lung lesion, can that wait a couple weeks? Can we do that right now? How much PPE do we need? So at our facility, I'm on this committee. It's an established perioperative committee, and it's myself and one of the vascular surgeons, general surgery is there, neurosurgeon, and a OBGYN oncology surgeon, and a representative from the cardiothoracic team is there along with anesthesia. So twice a day we meet. We usually meet for about 45 minutes to go over add-on cases from the night before that we're putting on for today. And that's trying to kind of have an established guideline for what we're trying to do, which is here for the last week or so, we've been trying to establish kind of a fire break mentality of that. One of the things you have to realize is if you have a patient come into your hospital, they're going to, at least if they come in for an ankle fracture at my facility, they're probably, even if they do an outpatient case, they're probably going to be seen and touched by probably anywhere from 25 to 35 individual people for the whole circuit to kind of get in and out of the hospital. And so if we know this is kind of spreading by number of encounters, if you can minimize the number of encounters in your area, you can probably help decrease the transmission in your local area. So that's been our group's kind of status in trying to, basically we've been adding on people already in the hospital because, well, you're already here, so let's take care of your, hip fracture. Let's take care of urgent emergent things that we just can't send you home with. And then we've been kind of delaying all kinds of other surgeries that now this week, if we haven't next week rather, it's been very interesting noticing one of the things that's been delayed have been cancer surgeries. So if you need a mastectomy or colon cancer surgery, or you need a VATS for your lung cancer, all those have been pushed off. And now we're kind of getting to a point where, through a combination of medical indication, but also social pressure locally, that that we're going to probably start some of those cases and triaging those and figuring out how to do those as efficiently as possible starting on Monday.
To add on to that, Alex, we have the Scripps Clinic where I work at is a little bit of a contained environment. It has an urgent care and then, the wards and ICUs, et cetera, still. But we have like 700 to 800 primary care doctors within our group now. So it's a big group. I think we have 800 people in our entire group, but a lot of primary care docs. What orthopedics has done is we're in the process of setting up an orthopedic urgent clinic, basically, so that instead of having to go through all those touches, the urgent care ER, that you go directly to an orthopedist or our PA, so that we're streamlining even that process instead of having to go through this long sequence of our usual sequence. It's very much going to be streamlined. I think your point's great about minimizing the number of touches that we have to have in order for an individual to get care is going to be very important, even on the outpatient setting.
Right, and particularly in like an office setting, how can you minimize the number of staff that are potentially exposed? You got to think about the MA you work with, or if you're lucky enough to have a scribe or your X-ray techs. How are you going to protect all those people too who are working for you if you're in a private practice or even in a employed situation? Because it's just as important for your staff as it is for your patients to kind of look out for everyone's well-being too.
Thanks. And I'm not cutting off the conversation. I'm just chiming in to remind people to raise their hand if they want to make a comment or question. We're able to shift into, I'm going to hold off on shifting into some of the other format, but I will have Paul just flip to our homepage slide just to highlight different topics that people have raised in the past of questions and issues that we could potentially talk about, and there's certainly a category of other. So Ryan, and I want to be respectful to not naming names or direct institution, but I do know there's an audience of vascular surgeons out there, and I think I'm familiar that your institution, as you described it, is in a situation where it's a smaller size. I'm curious about the quantity of vascular surgeons at the institution and whether they're experiencing or feeling any stress due to manpower issues, or what's other sort of generic comments from the conversations that you guys have about dealing with COVID?
So it's a real, Olympia is about 100,000 people, and the county has about 250,000 people, I think. So we have 2 vascular surgeons at our hospital. There are a total of neurosurgery staff. We have 5 neurosurgeons, which is probably a little more than maybe what you need in a city that size, but we're happy to have it right now. We have a cadre of probably 10 general surgeons, and then our group has about 14 orthopedic surgeons, and I'm currently the only orthopedic trauma surgeon there. So it's so in terms of manpower, it is a bit of a stress, but because you've cut way back on elective surgery, it's kind of come down to, if you're doing vascular, we've kind of restricted it to symptomatic, and some of the general surgeons are also vascular trained. So we've kind of, vascular surgery procedures have been limited to symptomatic carotids and limb salvage procedures, or amputations if limb salvage isn't successful or an option for certain people. And there's recently been an ACS published guidelines. I mean, the weeks it's amazing how quickly this all changes, but I think they published more diverse guidelines 48 hours ago, I think. I haven't had an opportunity to go review them yet, but the vascular guidelines were probably the most strict in terms of what cases to move forward with.
Yeah, and I think in their channels, they've been sharing a lot of that information around as well, trying to be a resource to their colleagues to give help and guidelines. And many places have developed that spontaneously on their own, but I think one of the ways to do a lot of this, and why we're talking even tonight or in general amongst each other, is to share information so people don't have to relearn a process that somebody else has already addressed. And there's always ways for improvement and modifying those. And I was going to mention the ACS. So again, there's several other avenues to get this information and links, but it's an evolving situation. So I think it's valuable to let people know when things have been updated or learned from. Greg, without, and again, I'm just sensitive to how I've seen some things on social media where people have gotten into trouble for expressing a challenge or dissatisfaction with their institution. I don't want any one of us, or you in particular, to get in any trouble speaking in a negative way. And I think you have an outstanding institution, so I don't even anticipate that. But from a standpoint of an institution of your size and of its character, elective surgery, as I understand it, shut down. What are some of the things that you're aware of your return to work? Like what are you gonna do? What's gonna happen to someone like you returning to work?
Yeah, can you guys hear me? Yeah. I have to admit, I really have to give kudos to the physician leadership where I'm at. They have been on top of this thing since day one, and again, like a real shout out to them. I really don't have much negative to say. I think they turned the corner fast, and we adapted very quickly. Yeah, like I said, they've shut us down for another 2 weeks. So middle of April will be the first time we're allowed to return to work potentially, but that's a moving target, is what they're communicating with us. What we have done though is we've actually set up telemedicine conferences now through Epic, and we actually have the ability to not only do the teleconference, but we are able to do video chat with our patients, and we're able to bill for them now based on the new Medicare guidelines that have been recently established for this very purpose. So in that sense, we're able to kind of keep the ball rolling. We're able to see some of our patients, especially those that can be seen from home, I would say. It's really going to make it a little bit challenging to do a physical exam, but you can do some things creatively, I think, to work that out. Where we've found some challenge though, Jeff, is that a lot of our patients are a little bit older, and doing this type of chat ends up being a little bit more challenging. Ironically, a simple phone call is just about as good. You can do that through Doximity, or you can do it through other sources. You can block your caller ID if you're worried about it. So there's other ways of doing this. We have a video app on our phone now that connects to Haiku, which is the Epic mobile app, and we can actually do all of our visits just right by the phone. So it's actually made things pretty reasonable for us on an outpatient setting, at least.
And just to qualify what I said, I wasn't expecting you necessarily to say anything negative. I was just trying to sort of preface it so that that we're sensitive to those issues. I actually think that in many ways there's so many things that your organization does well. I think even high functioning organizations though are challenged at this time. So there's still opportunity for improvement while being respectful of all the great things that people are doing to try and manage the crisis. So other questions or comments from anyone? Raise your hand if you want to speak on the microphone, put something in the chat. Any other panelists want to ask another panelist a question or make a comment? I want to thank Dale for her willingness to jump on and share her comments and questions as well. Would do is also kind of highlight in this discussion and kind of a direction towards closing out the webinar over the next 10 minutes or so. Paul, is there any benefit, or is it easy to share just the answers to the survey that people took when they logged in, just so they know what the general responses are on average? That's one thing that we also will do. And then, so general rating of wellness before the whole COVID-19 for our sense was in the 7 to 8. And then of those people that took the survey, and then for wellness now, what's that look like? Do I scroll up? Yeah, I get to scroll up myself. Again, the more variability, but certainly putting a stressor on a lot of us. And so that's kind of our point, is to try and provide an avenue where people know that one of the antidotes for wellness, lack of wellness, is peer support. So that's what we're hopefully trying to provide here in this venue, is knowing that we can connect and be with each other. Dale put up some comments as well as far as mental health is critical. Like many of us experiencing anxiety, says, I've been uncharacteristically anxious and have reached out to a licensed LCSW counselor, which was very useful, and the Headspace app is free. We put that in our initial opening comments. We can do that. A request from someone else for some great, any of the articles or stories that were mentioned on today, if folks can provide a link or reference to that specific article, that would be helpful. Particularly the one about the comments about testing in Seattle and the situation going on in Italy. So Greg, I don't know if you have that you could share with us. We can do it after the fact and just put it up on our screen at the next time we meet. And yeah, so we have to share solutions to the protection for surgeons physically in the operating room. And so any additional things like that people can share, that would be really, really helpful. Paul, can you click to the arrow on number 7? What I wanted to just put out to everyone that's on the call is just for you to think about, what will you do better this week to manage or improve your own wellness, and realize that that's something that we all need to be paying attention to. But I think real action items are critical, and whatever it is that you've either discovered outside this venue or through this call, hopefully you have some thoughts as to how you might answer that question. other comments? There was some things in the chat that I lost for a second. So anything I missed out on? Greg, anything else you want to say in closing?
No, I think what we mentioned before is, we got to take care of ourselves, and I would highly recommend that we use this opportunity to do that. And like I said, find a cadence to your daily, like a rhythm to your daily life. Take care of yourself spiritually, and emotionally and physically. Take care of your family. But certainly, if you don't take care of yourself, taking care of others is going to be a lot more complex. So got to make sure that we keep ourselves in great shape so that we can be as effective as we can for our families and our patients that need us during this time.
And Ryan or Dale, either one of you want to make any additional closing comments?
I don't have a whole lot to offer other than everybody stay safe, and if you are kind of out of work, come up with a plan for yourself to kind of find something or get caught up on things that you've fallen way behind on. That'll help make this into a more positive experience, I think. And
we'll go ahead and move to do we want to show, Paul, I'll let you chime in. You can either just listen to me and respond or actually respond verbally. Do we want to just, as we close and people drop off, put up our first couple of slides that were some of the learning points from the last call? Or do we want to just go to our closing slide? Yeah, let's put those up for a couple minutes for anyone that might have joined us late. And I might stop jabbering. I'm challenged by silence, like many of us are. So sometimes when I hear silence, I have to keep talking. But we could leave these up and let people see them. And leave any closing comments in the chat about questions you have, comments, feedback. We're always looking to get better ourselves at this. And so thanks everybody for joining us, and we look forward. We'll announce our next conversation, which we might do in about a week. And that one, I think we're going to be doing a midday time. Thank you, everybody.
Where do I send this article to?
Send it to us or send it to my email, or you can, or even give it Facebook Messenger it to me, and I'll then share it with everybody.
Okay. Paul, is this your email address? Oh, it's at no reply at Zoom. Never mind.
Yeah, you can also send it to team@surgeonmasters.com.
All right, I'll send it now.
And I really, really appreciate your time, and hopefully this was a little bit of a way. I mean, you've been doing some really cool things. We didn't talk about those on the main part, but what were the different shows that you've been on? You did a podcast and a show.
I did Good Morning America, Inside Edition, Dr. Oz, some local TV channels, a couple different podcasts, one for neurosurgery, and then one for a magazine called Charisma, and then I did another one today for someone else. It's good to get the word out there. People just need to hear from someone. I'm being personally affected by it, which is what I think people want to hear from someone that getting affected by it sucks. But I'll tell you what, I'm stuck in a room, and it does get my mind off of it. And if it helps people around me to sympathize with what's going wrong around people around the world, then the more we can make people aware of it, the better it is, so appreciate you having me.
Absolutely. Thanks again. And say hello one way or another when you're back in town.
I will do so. Look forward to it, Jeff.
All right. Take care.
Thanks, guys.
Bye-bye.
Thanks, Greg. Thanks, everyone.
Thanks, Paul.